strange since I'm supposed to talk about MRI and echo, and I will mainly do a clinical presentation because I think that MRI may have a place in predicting that, but that would imply that you do MRI in every single patient prior to your mitral surgery, which I doubt we usually do. We don't even do a TOE before sending the patients to the OR, so certainly not an MRI scan. So I've already shown that slide. There are two things that we can try to look at. First is the immediate failures that do occur within the first months after surgery or immediately days and even in the OR. And these are essentially procedure related. And then there is this second curve of patients that come back progressively over time because most of the time the disease progressed, and it could be surgically related, but most of the time it is disease related as well. So just a few words about the mechanisms of immediate repair failures. We already seen that this morning. I think that the first reason why it would fail in the operating room is that you're trying to address a disease that could not be necessarily repaired, but you give it a try. And as you've seen this morning, we can make distinctions between the type 2s, which are highly repairable, and almost all of them are repairable with some exceptions. Those with rheumatic disease, in which you can attempt repair in about 2/3 of them, but with moderately good results at long term. Although I will show you some data to indicate that in mitral regurgitation particularly, maybe the rheumatic are not as bad as it would seems at the first place. And then, of course, you have the ischemic ones. And as I said this morning, you can try to repair all of them, but some of them probably not worth trying. When you look at the causes of immediate repair, this is already quite an old story from Tom Marwick at the time he was at the Cleveland Clinic. You see that at that time, the most important cause of repair failures were LVOT obstruction. And as I will show you, 10 years later, this has completely changed because at that time we didn't know really what were the causes of this LVOT obstruction. So the surgeons did not take care sufficiently of the different parameters. But nowadays, of course, it has changed. We have learned from our failures in the past and improved our techniques. Incomplete repair is another reason why you would have a repair failure, and most of the time it's because you didn't identify correctly something that was there and that you missed. And of course there are some related to the surgical technique itself. We've seen that this morning already, the SAM, and I just wanted to remind you the essential characteristics. So the narrow mitral aortic angle, the long posterior leaflet, and the use of a too small a ring, which will bring the coaptation anteriorly in the LVOT and cause SAM. So this is something that you have been used to, and nowadays, as you see that 10 years later, the incidence of LVOT obstruction is only 9% of the failures compared to 38% 10 years before. So clearly, by identifying the mechanisms of failure, you can improve the surgical technique so that nowadays LVOT obstruction is probably one of the smallest cause of failure. And I already alluded to that this morning. Clearly, to have left behind some posterior leaflet prolapse or anterior leaflet prolapse, not recognizing that when you do a quadrangular resection, you will open up the indentations between P1 and P2 and P2 and P3, and that, of course, if you don't restrict enough the annulus, then you will have residual MR at that level. All of these are things that are well known and corresponds to the few patients, 5 to 10%, that need a second pump run. I would like to concentrate more on the late repair failures because they're linked partially to the progression of the disease, but also partially to some of the things that you're doing in the operating room. And I will tackle the three main causes, so degenerative, rheumatic, and ischemic. So again, from the work of Marwick, almost 20 years ago, more than 20 years ago, when you look at the cause of late recurrent mitral regurgitation, half of them are due to disease progression. Of course, you cannot prevent that because, you know, if you have a rheumatic disease, if you have a degenerative disease, it will progress over time. And if you operate on the patient very early on in his life, there's a good chance he will come with another caudal rupture later on. There's still some patients that do come back because you did not perform the appropriate surgery and you left probably some degree of mitral regurgitation behind, and this kept increasing with time. And then, of course, your sutures sometimes, for many reasons, may fall down and cause recurrent mitral regurgitation. Now, if we look at the incidence of this is the famous paper from Wim Flameng from Leuven, so the Flemish Leuven University. You see that if you forget about the freedom from 1+ MR, because these are not things that we care when we cardiologists, but the freedom from 2+ MR, you see that in the end, 7 years down the road, there's only 80% of the patients that do have this recurrent MR. So this will make about a 2 to 3% event rate for MR as the incidence of this. Now, if you look nonetheless at this paper, you see that at the same time the freedom from reoperation was 94%. That means that most of these mitral regurgitations are only moderate in severity and do not cause any symptoms that would trigger a reoperation. So there is a discrepancy, I think, between the reasons why we want to have a perfect results, and these are the data from the Mayo, and the real life. There are some patients with mild, moderate mitral regurgitation after the operation, and they're doing fine. So, of course, if the outcome is mitral regurgitation, it's a failure. But if the outcome is clinical, it's a success. And I think that should not be your goal, of course, but I believe that changing the severity of regurgitation is changing the course of the disease over time and makes a disease that is terrible, severe mitral regurgitation, a more milder disease with moderate MR. But that's my point of view. In the study of Flameng, clearly procedural factors were associated with this repair. Very often he didn't use annuloplasty ring. I think it's a mistake. He almost never used sliding plasty, so he had quite a few patients with SAM. And he used systematically caudal shortening, which is a technique that I think you guys don't use anymore because we know it's prone to failure. So these 2 to 3% event rate per year are linked to things that we've learned in the past that were probably not good and that you don't apply anymore. So this is a more recent study. Now we are again 10 years down the road, and you see that now instead of having 20% freedom from 2+ MR at 7 years, we have 20% freedom from 2+ MR at 15 years. And I think this is a more reasonable figure that we see in everyday practice. So taking care of the ring, of the caudal shortening, etc., by understanding the mechanism and the reason why it failed, allowed to have much better results. So I don't say we don't have any problems anymore, but clearly we have learned by our experience how to take care of this. But still, in 2011, the anterior leaflet prolapse continues to bear a lot of these repair failures. A word about rheumatic, because in the mind of many people, rheumatic mitral regurgitation is indication for mitral valve replacement. And these are data from the Carpentier group. And as you can see, we have here a 20 years follow-up of patients with rheumatic mitral regurgitation. And you know that these patients are not always type 3. When you tackle patients that are coming from developing countries and are very young in age, they often have type 2s, and they have this very strange combination of a type 2A, so you have an anterior leaflet prolapse associated with a type 3 at the level of the posterior leaflet, which is completely fixed and immobile. And in most of the cases, you miss a large deal of this posterior leaflet, and you have to use pericardium to patch that. You see that if you look at 10 years down the road, we have a freedom from reoperation, which is not bad at all. So once you've been able to achieve a successful repair, you know it's going to last for at least 10 years. And then it starts to fall down during the next 10 years, probably because of disease progression. So I don't think that based on this you should think about repair even in rheumatic mitral regurgitation. I'm not talking here about the stenotic valves and only the incompetent valves. Here also, if you don't use a ring, you know, you could think this is rheumatic valve, so the ring is fixed, is involved in the disease, so why should I put a ring? If you don't use a ring, you have a large recurrence rate. So again, something that you should probably think of. And of course, there are no randomized study, but that study compared by propensity scoring, repair and replace, I prefer to be on the red curve. Failures in ischemic mitral regurgitation have been looked at very extensively. Probably the most important data are present in this area. In the other areas, it is very surprising to see the paucity of data that we have about the causes and frequency. But here in ischemic MR, there's a lot of data in the literature. And what all these data tell you is that the tenting severity predicts the poor results of your repair attempt. That means if your valve is very restrictive to start with, you can imagine whatever you want, you will probably end up with a poor results, particularly if you only do restrictive annuloplasty. This is one example of the many studies published 5 years ago by the group of Quebec, in Laval, in Quebec. And you see that they made a lot of measurements about the tenting of the mitral valve, both for the anterior and the posterior leaflet. And in their study, there was one parameter that was really linked with recurrence of mitral regurgitation after a restrictive annuloplasty. It was the posterior leaflet angle more than 45 degrees. That means that if you, before the operation, you have a posterior leaflet that is like that during systole, so it remains half open if you want. Even if you put an annuloplasty ring, you will never be able to get sufficient coaptation for it to be long-lasting, and you know that you need to have at least 8 millimeters of coaptation length to be able to have a sustainable result after in an ischemic MR. There's another thing which is important and probably helps to understand why this restrictive pattern is important, is the degree of left ventricular remodeling. If you wait too long before operating your patients with ischemic MR and they have very large left ventricles with an end-diastolic dimension in diastole more than 65 or 50 in end systole, they're going to die anyway from their left ventricular remodeling and from their ischemic heart disease, not necessarily because of recurrent mitral regurgitation, but the fact is that in that population that you see the recurrence. So these are all the numbers that we need to look at before the operations, before sending the patients to a combined procedure with CABG and ring annuloplasty. So dilated left ventricle, a large stenting area, and restrictive angles at both the anterior and the posterior leaflets. So in conclusion, the immediate repair failures mainly results from the inability to appropriately repair the valve, and this is usually due to the presence of poor quality or quantity of the diseased valve tissue. Or it can also be due to SAM. It was a significant contributor to immediate repair results in the past, but understanding of the risk factor that are now systematically assessed preoperatively helps the surgeon to design techniques that bring the coaptation as posteriorly as possible. And finally, the late repair failures are mostly due to disease progression or inappropriate use of your techniques, but you have learned how to change that. Suture dehiscence may contribute as well. Thank you very much for your attention.